everyone. This is my general topic of changing material used for primary teeth. These are the content of my topic. Obturating material to be used in pulpectomy should be biocompatible and eliminate the residual pathogen, neutralize their toxic products, and prevent the canal reinfection to create favorable environment for the healing process to occur. Pulpectomy is defined as complete removal of necrotic pulp from the root canal of primary teeth and filling them with the inert resorbable material so as to maintain the tooth in dental arch, according to Matheson 1995. Zedo is the most widely used obturating material, but it has following drawbacks such as delayed resorption, concerns of toxicity. So, to overcome these, many obturating materials such as calcium hydroxide, iodoform combinations, endoflash, and herbal derivatives, they have been introduced with the promising result that can be used as an alternative to traditional zinc oxide eugenol cement. Optimal requirement of root canal filling metal. It should not be irritating to periapical tissue nor coagulate any organic remnant in the canal. It should have stable disinfecting power. Excess pressure pressed beyond the peg should be resolved easily. It should not be inserted easily into the root canal and removed easily if necessary. It should be easily inserted into the root canal and removed easily if necessary. It should adhere to the walls of canal and should not shrink. It should not be soluble in water. Should not discolor the teeth. Should not be radiopaque. It should induce vital periapical tissue to seal the canal with calcified or connected tissue. It should be harmful to the adjacent tooth germ. It should not set to hard mass, which could deflect the erupting succedaneous tooth. Zinc oxide usual cement. ZOE was discovered by Monaste and subsequently used in dentistry by Kisholm. It was first root canal filling material to be recommended for primary teeth as discovered by Sweet in 1930. Hashish et al. Studied the beneficial effect of eugenol. The amount of eugenol less in periapical zone immediately after placement was 10 to 4 and falls to 10 to 6 after 24 hours, reaching zone after 1 month, reaching zero after 1 month. Within these concentration, eugenol is said to have anti-inflammatory and analgesic property that are very useful for pulpectomy procedure. Limitations of zinc oxide eugenol. Enamel defects of succedaneous teeth following zinc oxide pulpectomies. According to Cole and Cedrian, it stated that there is no relationship between primary teeth pulpectomy and enamel hypoplasia. Incidence of enamel defect was not related to retention of zinc oxide eugenol filler, length of zinc oxide eugenol fill, and history of trauma or caries. Pulpectomy teeth rarely exfoliated later than normal, and timing of exfoliation was not related to retention of zinc oxide eugenol paste. Contrary to these results, Holland reported that subcutaneous incisors that replace traumatized primary incisors treated with zinc oxide eugenol pulpectomies have 2 to 3 times higher incidence of enamel defect when compared to normal teeth. According to Gerald and Ronk, reported a case of developmental arrest of premolar following overfilling of root canal of the second primary molar using zinc oxide eugenol formicrosol. According to Holland and Fuchs, uh, Moskowitz and Samara, malformation of successors is attributed to the cytotoxic and neurotoxic nature of eugenol. Retention of zinc oxide periapically. Allen, according to Allen, speculated that the resorption rate of zinc oxide eugenol and the root differed, resulting in a small area of zinc oxide eugenol paste possibly being retained. According to Burkett and Lockett, Spedding, Mortazavi, and Mesbahi stated that extruded ZOE resisted resorption and took month or 1 year to resorb. According to Cole et al., reported that when ZOE extrude, it develop a fibrous capsule that prevent resorption of the material. Thus, it has slow rate of resorption, has tendency to be retained over after tooth exfoliation. Area of cementation resorption were evident. Periodontal ligament exhibited intense and moderate thickening. Dentine resorption was not observed, where bone resorption was found. According to Flates et al., Cole and Cedrian, observed deflection of permanent tooth eruption in 20% of pulpectomized teeth that are extracted. According to Garcia Gode, Ranley and Garcia Gode, Praveen et al. Reported deflection of developing permanent tooth bud because of its hardness. Praveen et al., Sunitha et al. Excess metal forced through the apex during the filling procedure can remain in the apical tissue during the process of physiological root resorption, and it takes few months or even year to resolve. According to Sedrin and Cole, demonstrated that none of the retained zinc oxide regional particle caused any observable pathology and were also not released to treatment failure. Tissue irritation. According to Burken and Lockett, material when extruded from the apex caused mild foreign body reaction. According to Irescuen et al., reported that canal overfilling with the ZOE are not recommended because it irritates the periapical tissue and cause necrosis of bone and cementum. Antibacterial activity. According to Cox et al., zinc oxide powder had no inhibitory effect and addition of eugenol to zinc oxide retarded the growth of only the gram-positive organism. Early eruption. According to Leve, premolars erupt early after primary teeth pulpotomies. Possibly, a mild chronic inflammation exists in periapical area of some pulpectomies judged successful that is not clinically evident. This could cause premature eruption of subsidiary teeth and uneven resorption of pulpectomy treated tooth. Combination of ZOE. Mixture of ZOE and calcium hydroxide in sodium fluoride. In the study conducted by Chawla et al., a mixture of zinc oxide powder and calcium hydroxide paste in sodium fluoride displayed moderate inhibitory activity against Streptococcus epidermidis, Streptococcus mutans, Staphylococcus aureus, Bacillus subtilis, and other gram-positive and microorganisms. It showed weaker inhibition against Enterococcus faecalis. The improved efficiency of these material mixture could be attributed to the addition of fluoride, whose antimicrobial effect is well established. According to Cox et al., the inclusion of zinc acetate as a setting accelerator inhibited both gram-positive and gram-negative bacteria. Metapex and Vitapex are available in the preformed syringes, which are directly placed into the canal and are materially extruded into simple pressure. Addition of polysilicon oil in the Vitapex enhances fluidity and permeability, which also improves the collateral benefit of root canal filling. According to CO et al., the weak antimicrobial activity of Metapex may be partially explained by the fact that calcium hydroxide, an ingredient of Metapex, has been demonstrated to interfere with the antiseptic capacity of dyadic combination of endodontic medicament. Limitation of Metapex and Vitapex. Hollow tube effect. The faster resorption of Metapex and Vitapex causes voids in the canal, leading to formation of hollow tube. Intracanal resorption of calcium hydroxide form or calcium hydroxide paste stop disinfection or become hollow tube due to loss of paste. Tissue fluid containing bacteria can and fill the space in the unfilled and empty spaces. Or causes infection. This is called hollow tube effect. Shift the pH to acidic, dissolving root dentine cementum, initiating the resorpting process. These hollow tube effect initiate the resorptive process. The inflammation also causes transformation of non-differentiated cells of connective tissue into giant multinuclear cells, which are responsible for the resorption process. Antimicrobial activity. According to Kriplani et al., Harini Priya et al., Metapex has lowest and antibacterial activity than when compared to zinc oxide eugenol, Vitapex, and calcium hydroxide. However, it showed moderate activity against Streptococcus pyogenes, Staphylococcus aureus, Enterococcus faecalis, Pseudomonas aeruginosa, but failed to inhibit Candida albicans. So it was concluded from the study that zinc oxide antibacterial activity zinc oxide is more than Vitapex than calcium hydroxide than Metapex. Chow et al. Concluded calcium hydroxide with iodoform had exhibited no antibacterial activity. Calcium hydroxide was introduced by Hermann. It was antiseptic, osteoconductive properties. It is antibacterial effect is primarily due to liberation of hydroxyl ion and inactivation of enzyme in the bacterial cytoplasmic membrane. According to Estrella et al., verified influence of antibacterial potential of calcium hydroxide against Staphylococcus aureus, Enterococcus faecalis, Pseudomonas aeruginosa, Bacillus subtilis, Candida albicans. Shows significant effectiveness for calcium hydroxide paste for iodoform plus saline. Limitation of calcium hydroxide. Root resorption. The main drawback of the metal is that despite of its antiseptic and osteoconductive property, it has tended to resorb earlier than physiological root resorption. Calcium hydroxide, when used as obturating metal in hyperemic pulp, where it causes some vital pulp tissue remnants and can trigger the cascade of inflammatory root resorption. Calcium hydroxide paste, when used as obturating metal in necrotic pulp, causes damage to predentine, which in turn lead to exposure to dentine to odontoclast and subsequent resorption. Antibacterial activity. According to Abdul Qadar et al., calcium hydroxide associated with distilled water, saline glycerin was ineffective against several obligatory and facultative anaerobic bacteria. Iodoform. Castagnola, and Orley showed that iodoform pastes are bactericidal to microorganisms in the root canal and lost only 20% of their potency over the period of 10 years. It is commercially available as Vekoff paste, Moisto paste, Gidis Pinto paste, KRI paste. Component iodoform, parachlorophenol, camphor, menthol concentration. In 1989, a procedure was published for the root canal preparation and filling in the necrotic primary molar with the paste made of KRI and pure calcium hydroxide obtained in the high percentage of success with remission of all symptoms. This was the first publication in which formaldehyde was mentioned as a component of root canal filling material, thus partly recovering Buckley's formula, which contained 40% of formaldehyde and glycerin. KRI3. The liquid differs from commonly used KRI1 paste. These components are 12 times superior and hence possess greater antibacterial activity. Limitation of iodoform. Iodoform, because of their presence of iodine, causes yellowish discoloration of tooth. Few studies have revealed that it is irritating to periapical tissue and cause mental necrosis. This moisto paste composition: zinc oxide, iodoform, thymol, chlorophenol, camphor, lanolin. According to Pabla, reported that moisto paste had the best antibacterial activity. The antibacterial activity of moisto paste is greater than iodoform paste and then Zedui, then Vitapix. This formulation change was made with the intention of reducing the resorption rate of paste from within the canal of primary teeth. Reduced into paste. The composition is prednisolone acetate, rifampicin sodium salt, antibiotic, propylene glycol as a vehicle, microglycol, 30% parachlorophenol, 70% camphor, and iodine. Studied by Pretz et al. Confirmed that GP paste, Gides Pinto paste, had a favorable antibacterial action along with exceptional diffusion capability against all the microorganisms like Bacillus subtilis, Streptococcus aureus, Streptococcus mutans, Staphylococcus epidermis, Staphylococcus aureus, Enterococcus faecalis, Escherichia coli. Kellen paste. Pinto compared success rate of Zedoi and Kellen paste thickened with the zinc oxide. High success rate, but Kellen Zedoi was seen as these metal prevented pathological root resorption and induced new bone formation. Addition of Zedoi provide better consistency to the paste. Kellen Zedoi paste. In the study conducted by Quiros, the zone of bacterial growth inhibition of Kellen paste thickened with the Zedoi was slightly larger when compared to the Kellen paste alone, except for Staphylococcus aureus, suggesting that addition of Zedoi to the thickened Kellen paste did not interfere with the antibacterial activity. This due to Zedoi has also antibacterial activity. Composition: calcium hydroxide 50% of zinc oxide. Calcium hydroxide was 49%, 49.77%, colophony and polyethylene glycol. Endoflash. The rationale behind incorporating three metals zinc oxide, calcium oxide, and iodoform into endoflash was probably to compensate the disadvantage of one individual metal with the advantages of the other. Endoflash has the advantage of having resorption limited to excess metal, which has been extruded periapically within 7 days. Resorption of the material does not occur within the canal. Thus, the material is neither resistant to resorption nor does it result into hollow tube effect. According to Hedge et al., endoflask moderately inhibit the gram-negative, gram-positive organism and show a strong inhibition to candida albicans. According to Pelzer et al., the high antimicrobial activity of endoflask was probably due to the presence of iodoform and eugenol, both of which have antibacterial actions. Eugenol acts as a protein denaturation, while iodoform is an oxidizing agent. Even after the mature material sets, surface hydrolysis of the chelate zinc eugenolate result in the release of eugenol, thus explaining the effective antibacterial activity of thin substance even after 72 hours. Limitations. Radiolucent lesion following endodontic treatment of primary teeth worm may be due to filling material that contain phenol. Due to this, endoflask was developed which is free of chlorophenol. Chlorophenol was eliminated from the endoflask composition because of it has fixation effect which may affect the osteoblastic cells. Pulpotec. It is radio opaque, non-resorbable paste for the treatment of pulpitis by pulpectomy in the vital molars, both permanent and deciduous. Composition: powder polyoxymethylene iodoform excipient, liquid dexamethasone acetate, formaldehyde, phenol, guaiacol, alcohol excipient. Properties: pulpotec is filling phase for simple, rapid, and long-term treatment by pulpotomy of vital molars, both permanent and deciduous. Pulpotec has antiseptic, antibacterial, anti-inflammatory properties. The main component of this product is iodoform, and due to its antiseptic property, it acts as an antibiotic paste at the entry of empty root canal. Pulpotec can be used in the teeth showing bone lesion and help in reduction of clinical signs of infection. The clinical radiographic result shows that the procedure could be considered as an alternative to the conventional endodontic treatment for necrotic primary teeth in pediatric dentistry. Reprocod. It is a product formed from the corticosteroid and antibiotic, presenting a great antimicrobial action and recommended for the treatment of primary teeth presenting with the pulpal infection process. The paste also presented bactericidal action against most organisms except for Enterococcus faecalis bacillus. Lesion in recent years, Cardiology Research Unit of Niigata University of School of Dentistry has developed the concept of lesion sterilization tissue repair. The theory behind the lesion sterilization tissue repair is that the repair of damaged tissue might occur if the lesion is infected. This has also been referred as non-instrumentation endodontic treatment. A mixture of also called a triple antibiotic paste or polyantibiotic paste, antibiotic mixture. It uses a mixture of three antibiotic, metronidazole, ciprofloxacin, minocycline. The wall of access was chemically cleaned with DTA, chelating agent, which is used to improve the chemomechanical debridement because of its ability to remove the smear layer, allowing an antibiotic to penetrate into dental tubule. Pulpal floor is covered with the three mix. The procedure, which is termed as medication cavity. Mechanism of action. The metal can produce vascular changes in pulp involving inflammation and formation of granulation tissue with accompanying metaplasia of connective tissue and macrophages to form osteoclast like multinucleated giant cells. The remaining vital pulp tissue proliferate and develop new pulpal tissue into the pulp chamber. Lesion sterilization tissue repair. According to Hoshino et al., reported that rifampicin and component of 4 causes discoloration of teeth. According to Pinky et al., compared composition of two antibiotic based metals and ciprofloxacin and minocycline, ordinazole, ciprofloxacin and minocyclines. They were mixed in the ratio of 1 is to 3 is to 3, 1 part of ciprofloxacin, 3 part of metronidazole, 3 part of minocycline. They concluded that ordinazole had longer duration of action with better efficacy and slow metabolism compared to metronidazole. According to Seto et al., evaluation evaluated efficacy of 4 mix, that is 3 mix plus rifampicin. According to Takushige et al., preparation can be done in two ways: 3 mix syringe, 3 mix with 3 mix cannot replace conventional root canal treatment. Aloe vera. Aloe vera is a herbal natural acting a naturally found material and its property makes possible its usage in dentistry for various therapeutic purposes. It enhances various phases of wound healing process such as macrophages recruitment, collagen synthesis, wound contraction. According to Kherwa et al., evaluated clinical radiographic success of zinc oxide eugenol with aloe vera and showed good success rate. They reported that this metal can be used as an alternative to zinc oxide eugenol. Ozone. Ozone is a gaseous energized form of oxygen. It is unstable and dissociates readily back into the oxygen, thus liberating so-called singlet oxygen, which is a strong oxidizing agent. They are responsible for remarkable bactericidal and fungicidal effect. In the study conducted by Chandra et al., they there was a good clinical success rate at 12-month follow-up, which was attributed to the antibacterial and excellent healing properties of ozone peroxides. There is also progressive bone regeneration observed at the follow-up. ZOE had radiographic success rate less than that of ozonated oil, zinc oxide eugenol. According to the authors, concluded that it can be considered as a good alternative for ZOE. The current obturating material available, though, have marked success rate clinically radiographically. None of the material can considered as an ideal root canal filling metal. Zinc oxide, though, has antibacterial property better than other material. Concerns are raised regarding the delayed resorption and toxicity will limit its use in current practice. To overcome this toxicity, aloe vera and ozonated oil was substituted for the eugenol, and author reported good clinical and radiographic success rate. Hence, these metals can be used as an alternative to traditional zinc oxide eugenol. Calcium hydroxide combination was introduced into idea of matching the resorption rate with the primary teeth with that of primary teeth. But the major disadvantage with this metal are absorption very much earlier than that of physiological root absorption. To overcome the above material disadvantage, endoflask can be used, which has a property to resorption of extruded metal with no intracanal absorption. With the advent of non novel technique, the metal like LSTR and pulpotake necrotic primary teeth can also be preserved, thereby maintaining the arch integrity. Conclusion. Zinc oxide eugenol oil readily added the aloe vera can be used as an alternative to ZOE. Endoflask can be recommended in daily practices and it has better antibacterial property and resorption of only extruded material. In case of necrotic primary teeth, LSTR and pulpotec can be used to preserve the tooth. So, based on observation from the previous present study, this knowledge can be applied to our daily clinical practice. More randomized clinical trials should be conducted in the field of observation metal in the future with large sample size, such as studies comparing traditional metal with that of novel metal and herbal derivatives, with long-term follow-ups for sound evidence-based practices.